My name is Elsbeth McSorley, and I'm very excited to welcome all of you, and I'm happy to have so many of you joining us. Today, we're focusing on opioids, chronic pain, and REMS. Just to review the purpose of the PainEDU webinar series, this is a new way for us to communicate with the PainEDU community. We'll be sharing information and letting you know what we're developing. We'll be presenting pain-related topics that we hope are engaging and relevant, and it's also a chance for you to ask us questions and interact with us. Just a few webinar logistics and a little bit of housekeeping before we begin. Telephones must be used for audio and should be muted at all times. You will not be able to use your computer's microphone or speakers. Also, please don't put your phone on hold, and all questions will be answered at the end of the presentation. You should see something like this on your computer screen. Again, please select telephone for audio, and then you do need to dial in that phone number and use that access code. And all questions can be entered in the question chat box. Feel free to enter questions throughout the presentation, but like I said, we actually will be answering them at the end. And to review the availability of today's presentation, all attendees will receive an email after the webinar with a link to a recording of the webinar, and we'll also be sharing the presentation slides with everybody. I would now like to introduce our faculty member, Sina Wing Venuti. Ms. Venuti is the product manager of the pain management programs at Inflection, which include PainEDU, the PainEDU REMS Education Program, PainAction, our website for patients with chronic pain, and the Inflection Health Series publications, as well as our opioid risk assessment tools. She has over 10 years of experience working on pain management and opioid risk projects. Our second faculty member is Dr. Kevin Zakharoff. Dr. Zakharoff is a licensed board-certified anesthesiologist with more than 25 years of clinical experience in anesthesiology and pain medicine. He is the Vice President of Medical Affairs at Inflection, an active faculty member at the State University of New York Stony Brook School of Medicine, a member of the Board of Directors of the American Society of Pain Educators, and the Medical Director of PainEDU and PainAction. Dr. Zakharoff is a co-author of a number of our print publications, including the Guide to Pain Management.
Elsbeth, thank you very much. And it's really nice to be here with all of you, and welcome, Sina.
Hello.
Just a brief introduction. With respect to the subject matter and what we're trying to do today, we are fully aware of the fact that when it comes to opioids and the management of chronic pain, there's a lot of controversy. I think a lot of people in the pain management community think there is a significant understanding at the people who are on the front line on Main Street about what REMS is. But what we're going to try to do today is actually talk about REMS, hopefully give you in a chronological way a clear sense of what REMS are, how this all ties in to the use of opioid medications when treating patients with chronic pain, and give you some impetus to start thinking about this and understand it better, because we really are aware that there's a lot of confusion. So with that said, I'm going to turn it over to Sina so she can begin.
Good afternoon, everybody. We're going to be telling this story in a kind of chronological order kind of way, starting with the year 2000, which was kind of a hallmark year for pain management, and a couple of different things started in 2000. The first of which was a national survey of residency programs that showed a real deficit in education in both the areas of pain management and substance use disorder training. And the data came out that actually only about 4% of programs required pain management training. In discussions that I've had with Dr. Zakharoff, he often refers to his own medical training where he probably spent, a day or two on pain management and maybe an hour on opioids, and that was much more related to the pharmacology of opioids rather than anything, addiction or efficacy related. The other really important thing that happened in the year 2000 was that Congress declared 2000 as the beginning of the decade of pain control and research, and this legislation was passed and signed into office by President Clinton.
Yeah, and I think that's a really good point, Santa. The real point of it for me is that we've been having these kinds of discussions about pain management, education, and opioid use for a really long time, and the question is, what progress hasn't been made, or what progress hasn't been made?
So, a very important step that occurred, right around the same time, and brought this topic to front of light was that pain became known as the fifth vital sign. And there was really kind of a go-getter in this area who was a hospice and palliative care nurse by the name of June Dahl. And she was really paving the way, particularly for the cancer pain community. But once that stake was, once that claim was made, other non-cancer pain treaters followed suit. And the important things that came out of making pain the fifth vital sign was that that there had to be a pain control plan, that everybody walked into the doctor's office, and along with temperature and other vitals, healthcare providers are supposed to assess every patient's pain on that 0 to 10 pain scale and document it. So the successful pain control plan, which you can see on your screen, includes establishing a diagnosis, treating the cause of the pain whenever possible, optimizing pain relief, implementing non-pharmacological interventions such as nutrition and diet and exercise and massage, to maximize physical and psychological comfort, and particularly set realistic goals around function. And when healthcare providers feel like they are kind of over their head in managing pain, they make referrals to people who have further education and training in the area of pain management. So, the decade happened, and we found ourselves in 2011 with a response from the White House declaring that the United States was facing an epidemic, and came out with a report which is called Responding to America's Prescription Drug Abuse Crisis. And they acknowledged the statement below, although there have been great strides in raising awareness about the dangers of using illegal drugs, many people are still not aware that the misuse or abuse of prescription drugs can be as dangerous as the use of illegal drugs, leading to addiction and even death. So just kind of taking a look at the landscape of the environment of pain management and who is prescribing. I'll get into a little bit more detail of the actual breakdown on the next slide, but people are prescribing include both experts and non-experts. The next slide will actually show the settings and where the pain patients are presenting and who is doing the prescribing. But the real takeaway here is that it's mostly non-expert clinicians, There are only about 4,000 physicians who are board certified in the area of pain management. So most of the people who are doing the prescribing are in family medicine and internal medicine, and also dentists are doing a lot of the prescribing, particularly with the young adult and adolescent population, and that many or the vast majority of prescriptions were for hydrocodone and oxycodone containing products, and they were issued basically for acute pain conditions rather than chronic pain conditions. And this data actually came out in JAMA back in 2011 by lead author Nora Valco, who is actually the director of the NIDA program at the National Institutes of Health. So this slide is one that we internally focus on a great deal here at PainEDU, and this actually takes a look at in what settings prescription opioids are prescribed, and there's a lot of misconceptions about that. So looking at the breakdown, you know, nearly 40% of prescription opioids are coming out of emergency rooms. 30% are coming out of primary care offices. So that means that really only 30% of prescriptions that are being written are coming out of specialty settings, you know, surgical offices, specialty offices, and you know, following outpatient procedures. All right, so that sort of paints the landscape and gives a picture of kind of how we came to be where we are today. And now we are going to get into a little bit about REMS and what they are. So REMS stand for Risk Evaluation and Mitigation Strategies. And back in 2007, the president signed into law, you know, the policy of REMS, which is basically giving, for the first time, the FDA the authority to require and enforce pharmaceutical manufacturers a plan to show that a medication coming to market, you know, has been measured to determine that the health benefits outweigh the potential risks and side effects. And Kevin will get more, you know, into depth on what the definitions or what the current definitions of risks are today. But the important thing to note is that this does give the FDA new authority. REMS are required as part of a new drug application for drugs that, you know, that do carry a certain amount of weight in terms of risk, and that REMS are enforceable, meaning that if, you know, if there are enough adverse events that occur, that a drug could be removed from the market.
Yeah, and that's a really important point, Senna, and I think it's good to keep in mind that typically the Food and Drug Administration has had the ability to govern the pharmaceutical manufacturers, and not a significant amount with respect to clinicians like me who practice medicine. The most interaction that I would have likely with the Food and Drug Administration is reading the label of a medication and the Food and Drug Administration determining what that is. When the FDA got this authority from the Food and Drug Administration Amendments Act back in 2007, it allowed them to act in a way that was a little bit closer to the clinicians who are practicing medicine, where typically it's the Drug Enforcement Administration that interacts with the clinicians and the Food and Drug Administration interacting with the pharmaceutical manufacturers. So this is the beginning of a way that the FDA could interact with more of the stakeholders in the story.
Yeah, it's a shift in paradigm.
Exactly.
Okay, really quickly, and then we'll get into a little bit more about the implications, excuse me, on the following two slides for both healthcare providers and for patients. The real goal of REMS is, the desired safety-related health outcome, or the understanding by patients and healthcare providers of the serious risks associated with certain medications. So for healthcare provider, possible REMS components include demonstrating particular experience around prescribing a particular medication, documenting that they've received specific training in prescribing that medication, and in some cases even receiving a quote-unquote certification showing that they have been, certified in the risks associated with prescribing a certain medication. And, REMS are not a new concept, as, they've been around for a while, and medications outside of the opioid realm have had REMS associated with them for a number of years, and a couple of examples of medications that have been around for a while that have had REMS include the drugs thalidomide and Accutane. Possible components for REMS for patients include that they have been properly counseled and that they have a demonstration that they understand the benefits and risks associated with the drug, and this must be documented in the patient's medical record. Going back to the examples of thalidomide and Accutane, there are actually registries that the patients are linked to, so that there is clarity and transparency and documentation that this education has taken place. At this point, with the opioids, a registry has not been required, but that is something, that eventually, could come down the pipeline.
Right, and, in probably an example of its most drastic form with thalidomide, in order for the pharmacy to dispense the thalidomide, they have to have a pregnancy test that is 24 hours old or less in order for them to deliver the medication. So it's just a really good example about how restrictive these medications can be in certain circumstances. And there's somewhere around 100 or more medications that have REMS associated with them. So let's move on and just, Cinna did a good job of setting the landscape with respect to what was taking place over the course of that decade of pain control and research, and then that hallmark period of time, 2011. But let's just spend a little bit of time talking about chronic pain so we could weave this into the story. It's probably not very surprising to the majority of you on this webinar that pain is one of the most common reasons that people seek medical attention in the United States. I think most of us refer to a hallmark report that came out in, again, 2011 from the Institute of Medicine that looked at chronic pain in the United States and really gave us some numbers to think about as we wrap our heads around the issue of chronic pain. And
I believe, according to that report, the statistic is that 1 out of every 3 people presenting to a healthcare provider is there for some form of pain.
That's right.
Or a pain-related complaint.
A pain-related complaint. And they estimated, in their original report, they actually said 116 million people, but they cut it back actually to 100 million people at any given time in the United States are suffering from a pain-related condition, a lot of those people with chronic pain. So it's a prevalent condition in this country. That coupled with the fact that there are new conditions being identified, such as fibromyalgia, which is not a diagnosis that's actually that old, or even the redefining of reflex sympathetic dystrophy to 2 different types of chronic regional pain syndrome. There's a lot that's been happening in the chronic pain area. And this report from the Institute of Medicine talked about the prevalence, but they also talked about the economic consequences, which was really shocking to a lot of people, whether it's the result of cost of healthcare, productivity in the workplace, and they estimated that the financial burden of chronic pain in the United States is somewhere between 565 and 635 billion with a B dollars each year in the United States. So if we talk about chronic pain, the likelihood is at some point in time we're going to think about opioids in some way, shape, or form. And there's a lot of controversy I'm sure most of us are aware, in some way, shape, or form regarding the use of opioids in the treatment of chronic pain. But we also need to consider the fact that they have been demonstrated in some cases to be the go-to treatment if all other treatments have failed. And we also need to consider the fact that alternatives to opioids also carry their own risk. I have read statistics about the risks, particularly to NSAIDs and COX-2s, where people talk about a significantly large number of hospitalizations and even deaths related to their use on a chronic basis. And I think that while we are not purporting any answers to the question about the controversy about opioids for the use of chronic pain, we do at least have to understand that there are certain situations where they can be used safely and effectively if they're prescribed appropriately by prescribers and if patients understand the risks and the benefits associated with their use and the responsibility. And hopefully you out there are starting to see how we're tying this together with respect to what Cinna said about REMS and what I'm saying about chronic pain, and see how this all converges on what we're going to spend a significant part of this talk discussing. Now, from the healthcare provider perspective, a lot of what we've talked about specifically with treating chronic pain, especially with the use of opioids, presents a number of challenges to healthcare providers for sure. From policies that are either regional or institutional or national, or guidelines that come out from a variety of different organizations, such as the joint guidelines that were released from the American Pain Society and the American Academy of Pain Medicine back within the decade of pain control and research for the treatment of chronic non-cancer pain with opioids. Even the Joint Commission, about a year and a half or 2 years ago, sent out a sentinel alert on the institutional use of opioids. So there's a lot of different guidelines coming from a lot of different places, and this can often be very confusing to healthcare providers and present challenges. With respect to expectations, I could tell you personally that when pain became the fifth vital sign, one of the things that was a culmination of was the fact that there were actually patients bringing litigation against healthcare providers for the undertreatment of pain. And some of these litigations were actually successful. There was also a patient bill of rights developed that gave patients certain rights with respect to the fact that pain needed to be assessed and that it was assessed and appropriately treated. That, coupled with time constraints, which any of us in healthcare know are ever increasing. We know a number of people in primary care who say they have 7 minutes or less to spend with the average patient, mixed with the fact that these patients who are presenting for treatment are complicated. Even though we know that there's a high prevalence of chronic pain, if people haven't been thought about it, the likelihood is it's not very high in their problem list when they're spending this limited amount of time that they have to spend with patients. And this is a challenge. Additionally, Cinna mentioned the lack of training in many cases. And the data that Cinna was talking about of only 4% of training programs in the United States for internships and residencies and even medical school dealing with chronic pain presents a challenge because they're being faced to make decisions about treating something that in many cases they haven't received the education about how to treat. And then lastly, the regulatory scrutiny, which we've talked about briefly, but it's coming, these challenges are coming obviously from a lot of different directions to healthcare providers. Wouldn't you agree?
Absolutely.
I said I'd be talking about this, and this is a pared down version of my discussion about this, but when I was trained back in the early to mid 80s, the definition for me with respect to opioid risk was adverse effects, side effects that could occur, and respiratory depression was the elephant in the room. Anytime anybody prescribed an opioid, they were worried about the patient having a respiratory arrest related to the opioid. And in the pain management community today, I think it's fair to say, and we are at most of the meetings every year, that if you mention the words opioid risk at those meetings or to people in those communities,
or to the FDA.
Or to the FDA even, good point, the likelihood is they're not thinking about adverse effects. They're there in the back of their minds, but what they're really thinking about is aberrant drug-related behaviors, namely abuse, misuse, diversion, addiction, and most importantly, unintended deaths. And it is worth noting that there are a number of states in the United States where more people are dying of unintended deaths related to opioids than automobile accidents. And I think that that is sort of going to be bringing us to the focus of today's talks even more. Because this really, really concerned the White House when they came out with that document back in 2011 that Sina referred to.
Okay, so this is a slide that some of you are probably familiar with. It comes from the CDC, again in 2011, and this is sort of a snapshot of what we looked like at the beginning and the end of the decade of pain control and research. You know, back in the year 2000, you know, overdose rates were relatively low, and they were relatively consistent between analgesics and, you know, illicit drugs. And now if you look, you know, this data goes, I think, to 2008, but if you look at where we are, you know, at the end of the decade of pain control, you can see that people were really concerned about undertreating, and they started responding with their prescription pads, and more, you know, prescriptions for opioids were being written. And here we are now at the opposite end of the spectrum, where unintentional overdose deaths for opioid analgesics, you know, has surpassed significantly the unintentional overdose rates of deaths for both cocaine and heroin.
Yeah, and Sina and I were actually talking about this before the webinar began. Just on this past Monday, I received an email from the White House Office of National Drug Control Policy talking about new data that had just been released from the CDC. And, you know, there's always a lag in the data, so this data is actually referring to 2013 mortality data. But what this data showed was that there was no significant real change in drug deaths related to prescription pain medications from 2012 to 2013. But one thing they did see is that deaths related to heroin use were starting to increase. And actually, that was the third year in a row that heroin-related deaths had gone up. And it begs the question that as the opioid controversy rages on, and as education about their use continues, you have to wonder whether or not there's a development of what we refer to as a balloon effect, where you squeeze the balloon and the air moves over to the other side, and it becomes about what is going to be most easy and convenient for people to get their hands on, and what costs the lowest amount. So it's just interesting to see that this kind of situation still exists, but that heroin is starting to come back onto the radar screen.
All right, so this is an image that has always stayed with me. It came out in the New York Times back in 2011, and actually, coincidentally, Dr. Zakroff and I were doing a series of talks in Florida about their prescription drug epidemic when this came out. And it was a huge issue in Florida, and I remember a lot of people coming up to us after our discussions talking about the issue that they were facing with neonatal abstinence syndrome in their NICUs, where there were all of these babies being born dependent on opioids. And you know, this is an image that corresponds with the New York Times article that shows a baby, you know, being given opioids to prevent withdrawal, you know, hours after being born. And some reports indicate that in any given NICU, 1 out of 10 babies on the unit are being treated for neonatal abstinence syndrome.
So if you think about everything that we've talked about up until this point, I think it brings us right to here, which is what I always refer to as the letter. There was a letter that was sent to all manufacturers of extended-release long-acting opioids from the FDA, letting them know that a REMS was going to be required for this class of medications. Now, while we referred to the fact that other medications had had a REMS associated with them, one of the hallmark aspects of this was this was really the first time that the FDA was going to make a decision to require a REMS for a number of different medications at the same time, and that presented a number of challenges. It's also worth just briefly mentioning the fact that there were a couple of things that happened as the FDA got to this point. There was a lot of debate that took place in a number of different FDA meetings about whether or not this should be applied to all opioids, or immediate release short-acting, or extended release long-acting. And basically what the FDA decided to do was they wanted to just take a good first step and have this apply to the extended release long-acting opioids. And you know, what they substantiated for their rationale was that this formulation of opioids has more medication per unit dose in it, and that made it significantly more dangerous. They felt that also made it possibly more likely to be a formulation that was attractive for abuse, and that it could be much more likely to result in either accidental or even in some cases intentional overdose. So it was a measured decision, I guess, is the way that I would describe it, that the Food and Drug Administration decided to limit this just to the extended release long-acting opioids. Now, at this time, when the letter was sent out, immediately a number of stakeholders sort of popped out, such as the Federation of State Medical Boards, the variety of government agencies that might need to be involved, including the Drug Enforcement Administration. Obviously, this was going to present the potential to impact prescribers and patients and consumer advocates and caregivers, pharmacists, and the like. And even the professional societies were impacted in some way, shape, or form, and in many cases had position statements that they released based on this decision by the FDA. So today in 2015, I think the thing that we would like to focus on, being that we are from PainEDU.org, is the prescriber education. And Sina, maybe you could just briefly talk about this.
Sure. So, yes, a hallmark decision was made that prescriber education was to be a huge component of REMS. And the interesting note about this is that while the education is strongly encouraged, it is a voluntary activity and it is not mandated. And there is no registry, and it is different from some of the product-specific REMS. But key pieces of the education include information about appropriate patient selection, dosing, and monitoring, training for patients, and counseling on the safe use, storage, and disposal of opioids, demonstration by sponsors of prescriber training, and that the knowledge of appropriate use was improved via surveys of the prescribing community. So basically, the pharmaceutical manufacturers of this class of drugs needs to report back to the FDA that this education is taking place and that it's effective. And additionally, as I mentioned earlier, that there's no formal enrollment or real-time verification.
And when the FDA made this decision, they notified the manufacturers of the ERLA, or extended release long-acting opioids, and they also developed what, again, I think most people know what this means. What they refer to as the blueprint for this education for healthcare providers. Basically, it's a detailed curriculum outline covering all of the points that the FDA felt it was important for this education to cover. And it outlines that prescribers, as Cinna mentioned, should know how to assess patients appropriately to determine whether they're appropriate candidates for ERLA opioids, to be familiar with how to manage therapy from beginning to end, in the middle, and even when they needed to be discontinued, and how that should be handled. To be knowledgeable about how to manage ongoing therapy, and also to be knowledgeable about how to educate patients and caregivers about the safe use of these medications. And we can't underscore enough how important they felt it was to focus on proper storage and disposal, which is a topic of discussion in and of itself. Now, in addition to that, something that was also included in the FDA educational curriculum was education about both the general and product-specific information with respect to ERLA opioids. So familiarity with the class and things that impact patients' safe and benefit risk profiles of all of the medications versus the individual specifics about the medication formulations themselves. From the patient assessment perspective, the blueprint outlined a lot of detail about consideration of risk and how to balance that against the potential benefits, as you could see. One thing that did pop up on the radar screen and that became a very key point of this was inadvertent exposure to household contacts. I refer to transdermal formulations of these types of opioids as something that still has opioid within it after its therapeutic life has ended.
Not to mention buccal and transmucosal.
Exactly. And in some situations, there were situations where transdermal patches were placed in the kitchen garbage, for example, and children or either pets came into contact with it there, put it in their mouths, and unfortunately had unintentional overdoses themselves. With respect to initiating, modifying, discontinuing therapy, the things that the curriculum from the FDA made points to stress were the awareness that every prescriber have of both federal and state regulations. And it's important to note from a state perspective, many states are different from others, particularly with prescription drug monitoring programs, for example. Consideration that dose selection is critical, and when dose selection is made for the ERLA opioids, that equal analgesic dosing concepts be employed, and that there's some framework that people use that's reproducible. With respect to managing ongoing therapy with ERLA opioids, clinicians have an understanding of clear establishment of goals of treatment, strong urging by the FDA that there be use of patient-provider agreements, although this was not mandated or recommended to be mandated, but it was certainly underscored about their value, particularly probably from a documentation perspective as well, and assurance in some way that patients are being adherent to the treatment plan. Also, education for healthcare providers about how to monitor patients, whether it's observational, interviewing, accessing PDMP data, using specific screening tools such as the SOAP or the ORT tools, understanding when drug screening needs to be utilized, such as UDTs, and also other tactics such as medication reconciliation. One thing that I think we can all say is that from the counseling of patients and caregivers, most of us have probably relied on the medication guide to do that job. But what the FDA wanted to make sure was through this education that prescribers have a clear understanding of the fact that they needed to provide counseling on a product-specific level, on a warning level against modifying the extended release long-acting opioids because they do have an extended release mechanism within them, and that crushing them or chewing them could defeat that mechanism. Extreme caution about use of these medications with other CNS suppressants, particularly, again, because these are sustained release formulations. What the signs are and symptoms of withdrawal, and warning patients about sharing these with other people. From the general information perspective, nothing surprising here. General characteristics, toxicity, drug-drug interactions, tolerance, and then specifics about the formulation and delivery system itself. Now, on the specific side of the education, it was particularly focused in the blueprint on knowledge related to the molecule itself, dose formulation and strength, dosing interval, key instructions to convey to patients and caregivers, what the major drug interactions people needed to be on the lookout for, and whether or not even the specific agent was approved or appropriate for use in opioid naive or opioid intolerant patients versus opioid tolerant ones.
Okay, so one of the things that happened was that the FDA told all of the manufacturers of the ERLA opioid pharmaceutical companies that they had to work together and invest large sums of money to award grants to different organizations and institutions to develop REMS education programs. And PainEDU, in partnership with Albert Einstein College of Medicine and Montefiore Medical Center, applied for and was awarded one of these grants. And the curriculum, which maps directly with the FDA blueprint, was created by Dr. Zakharoff and Dr. Shafrin at Montefiore. It is currently a web-based program which consists of 3 hours of CME, which is 3 AMA PRA Category 1 credits, and focuses on the safe and effective management of pain with ERLA opioids, as I mentioned, mirroring the curriculum of the blueprint. And you know, it's geared towards prescribers, but it's actually very relevant for all kinds of different healthcare professionals. It is a very nice complement and a first step in the education that PainEDU.org offers in continuing pain management training. We recognize that, you know, opioids is just part of many different treatment modalities, but feel like this is a really good place to start in your education. And I'm assuming most of you are aware of PainEDU, since that's how you probably receive notification of this. But you know, we have lots of other resources that can complement this education. The web-based program itself was designed and based with key learning design principles. It is highly interactive. In addition, there's self-reflective and motivational questions throughout the course. It's not something that you need to sit down and devote 3 hours of consecutive time to complete. You can start and stop it at your own pace, and that it's important to know that you don't receive all of the credit hours until you've completed the full 3 hours, of training. And then moving on, just to take a look at the different modules that we offer. It's broken down into 3, the first being the fundamentals of safe and effective use of ERLA opioid analgesics in the management of chronic pain. The second module is safe and effective management of ERLA opioid analgesics in therapy. And then the third, you know, again, mirroring what Kevin just spoke about in terms of the curriculum developed in the blueprint, are general concepts and information about ERLA opioid analgesics.
Yeah, that's exactly right. And, you know, I think in summary, I'd like to sum up quickly with a couple of key points. We spent a decent amount of time talking about the curriculum that the FDA came out with. What we didn't mention that's worth mentioning is that the FDA also required that this be delivered in a continuing medical education format. That one of the things that people could get out of this is continuing medical education credit. And a number of states do require that some portion of your continuing medical education credits be devoted to pain. Not all of them, but it's important for you to know which states, if you're practicing and you're a prescriber, do make this requirement. The other thing is the fact that Cinna mentioned, and I'd like to underscore, is that we really felt that we could do a service to the healthcare community and the patient community for that matter, because we didn't consider this REMS education program that we developed to be a one and done situation. That we really felt this could be a very good start to developing a relationship with people, with providing people with a solution, and having PainEDU and even our patient-facing website, painaction.com, for chronic pain patients, all fit together and sort of be a continuous way to get educational resources, not just a single 3-hour-long activity that would be discrete and may not, at the end of the day, provide a lot of value to people. So with that, I'm going to turn it back over to Elspeth, who has been fielding questions from you, and we will spend the next 10 minutes dealing with questions. And then Elspeth will also deal some details about post-webinar related activities too. Elspeth?
Excellent. Thank you, Ms. Benuti, and thank you, Dr. Zakharoff. People would like to know, what is the cost to take our REMS CME?
There is no cost.
Right. One of the things that the FDA was clear about is that when they said to the pharmaceutical companies that they needed to join together and fund this program or these programs, that this be available at little or no cost to learners. And in keeping with pretty much our PainEDU standard, none of the educational resources that are available on PainEDU have any costs associated.
Excellent. Thank you so much. Would you just clarify, is REMS training mandatory for people to prescribe? Is it becoming mandatory? Could you just clarify that?
Yeah, when the FDA was going through the process of making decisions about this, there was a lot of discussion by their advisory panel, which strongly felt in a majority way two things. One is that it was worth considering this education and this REMS entirely be devoted to all opioids, as I mentioned earlier. And then the other thing the panel felt strongly about was it might make a lot of sense to make an education like this mandatory. Unfortunately, the Food and Drug Administration doesn't have that authority. The Drug Enforcement Administration does, and state licensing boards do. So there is the hope that someday there will be a mandatory component to this. But right now, with respect to the ERLA opioid REMS, the word mandatory only applies to the relationship and the requirements that the FDA placed on the manufacturers, not with respect to healthcare providers in the United States at this time. It's a voluntary educational activity, highly encouraged, but voluntary.
We have a number of pharmacists on today's webinar, and they are wondering if they can get credit from our REMS program.
So this is a question that we've discussed with our partners, Albert Einstein College of Medicine and Montefiore Medical Center. And I believe what they said to me, that there are often situations where continuing education that's accredited for physicians is reciprocal to pharmacists. You know, that would be what I would say at this point in time. Although we do have future visions of morphing this into a program that wouldn't require reciprocity. But, you know, on talking with a number of pharmacists that I know, the majority of them have told me that they will get reciprocity for continuing education that is accredited for CME for physicians.
We have a number of questions coming in. Our program, the REMS, is for ERLA opioids. We have a number of people asking why REMS is not for all opioids, and more specifically, why there's no REMS for short-acting opioids.
I don't know. I don't know what you think, Cinna. My answer to this question is probably tune in another 5 to 8 years, and the answer will be a little bit different. You know, we haven't brought this up, but you know, clearly when the Food and Drug Administration made this decision, they also made it crystal clear that the intention was not to deny access of these medications to patients. And this was very, very carefully considered. There have been a number of steps that the FDA has taken, actually, within the last 12 to 18 months to tighten things up a little bit with respect to rescheduling of hydrocodone products and the like. But the FDA consciously made the decision to do this, I think, for two reasons. One, it was what I call a human bite. They were taking a small bite at the beginning. They wanted to see how it goes, see what the manufacturers were going to report back to with respect to the success of the education in terms of metrics, and then take a look and see. The other thing is that we need to realize is very often the extended-release long-acting opioid medications are the preferred substance of abuse for people who are looking to abuse and misuse them, because they have more medication per unit dose. So they looked at this as probably a good solid single, knowing that in order to achieve a home run might take a little bit of time.
Great. Thank you, Dr. Zakharoff. I'm going to end with this last question. People want to know, so if they do complete our REMS program, what do they do with the certificate? Do they show it to people? Is there a registry? How will people know if they did the REMS? And kind of what does that mean for them as a clinician if they have completed a REMS program?
So this is a really important and great question. Because a lot of people, when they do certain opioid educational programs, don't know if they're what we call quote-unquote REMS compliant or FDA certified, I think it's really important for the learner to know if it is. When you take the program on PainEDU and you complete it, you'll be sent a PDF of your certificate of completion for the 3 credits. What I can tell you is this. I can tell you that a number of organizations, a number of healthcare systems, a number of institutions are making this a requirement in order to ensure that there's safer and more appropriate prescribing of these medications. The fact that this isn't specifically directed towards immediate release short-acting doesn't mean that most of the educational material doesn't apply to all opioids in general. You have to assess patients appropriately, you have to monitor them appropriately, and so on and so forth. And you have to counsel them appropriately. So, you know, I think that coupled with the Joint Commission's sentinel alert about the fact that even within institutions, these kinds of things need to occur, means that everybody is sitting up and taking notice. And if it were me, what I would do is I would take the education, I would keep that certificate handy, and then if somebody was going to say, much like in New York, where I'm licensed for the infection control course, oh, you know what, we're requiring a REMS education course. Oh, that's something I've already completed.
Or a risk management course or an opioid safety course. This meets all of those criteria.
This meets all of those criteria. It
counts as a pain management course.
Yeah, it counts as a pain management course for state requirements, and it does track back to the Food and Drug Administration at the end of the day. So I think it's really important for all of us to keep that in mind. The likelihood is the educational requirement is not going to diminish. It's going to increase. And, you know, I think some percentage of us are quote-unquote early adopters, but we can't deny the fact that in many cases the majority of us haven't received formal education on this important subject. And this is one way that we could achieve that goal.
Excellent. All right, well, we are going to stop it there with questions and answers. To all our attendees, we hope you enjoyed today's webinar. We would greatly appreciate your feedback, so please take a few minutes and answer the post-webinar survey that you will be emailed later today. We invite you to visit.
Sorry, Elizabeth, to interrupt. I just wanted to point out this last screen that has information about how you can access the PainEDU REMS Education Program. And if you want additional information or if you have additional questions specific to the program, you can contact us at the phone number that's on your screen right now, or you can email us at the email address that's there. We'll be happy to consult with you. We'll be happy to answer questions, and we'll be happy to you know, help you figure out how you can bring this education into your healthcare system.
Thank you. That was exactly what I was going to say.
Sorry, Elsa.
So, yeah, a lot of people were asking about the website. Again, it is rems.painedu.org. And if you get our newsletters on Wednesday, we always have something in our newsletters that link to that website. So if you forget that link, just remember to check your Wednesday PainEDU newsletter.
Right.
So finally, thank you. Oh, sorry, Dr. Zakharoff.
I was just going to say, obviously, anybody could go to PainEDU.org and they could find the banner that they could click on to get here as well.
Our next webinar will take place in the spring, so stay tuned for details, and we will look forward to having you join us then. Enjoy the rest of your day, and thank you so much for attending today's presentation.
Thank you, everybody.
Thank you. Bye-bye.